Thank you so much for the invitation. I'm pleased to be co-hosting this panel with Leslie Lowe, my co-chair, who is an RB mum and super organizer, as you will see from her presentation. We have for our panel today Vera Ezuman, who's joining us from Ghana, who's an RB crusader and pediatric ophthalmologist. Brenda Gallie, RB ophthalmologist and scientist in Vancouver, and myself from Vancouver, British Columbia. I am talking to you from the unceded ancestral territory of the Coast Salish people. So we're going to have the parent perspective, guidelines and retinoblastoma treatments, the national program in Ghana, new treatment discovery journey, and then we will have a roundtable discussion with Sammy Solomon from Egypt and Toronto, and Ashwin Malapatna, who's been in India, Australia, and Toronto, to join us in discussing retinoblastoma. And now I would like to turn over to Leslie to start. Thank you.
My name is Leslie Lowe. I am mom to 5 boys, including identical triplets named Thomas, Mason, and Luke. When the triplets were 3 months old, my husband, who is a doctor, had some concerns about Mason's eye. And he took him into a dark room and took a photo with a flash. And one eye came back with a red reflection and one eye with a white, as shown in my slides. He knew right away that that was something that needed to be investigated, and we went to see some specialists, and within a few days, all 3 of the triplets had been diagnosed with bilateral retinoblastoma, and we boarded an airplane from Edmonton, Alberta, Canada to Toronto to begin receiving treatment. That was about a 2,700 kilometer trip, and we had to make that trip several times during their treatment. On their first examination, we learned that even though they had identical genetics, the cancer had presented itself very differently in all 6 of their eyes. We were very fortunate that each of them had one really good A grade eye. But as you can see, Thomas's right eye was worse, and Mason and Luke's left, let's think here. Yes, and Mason and Luke's left eye was worse. See, I mix them up still. Anyways, so immediately after that first surgery, we had a really big decision to make. Thomas's eye was severe enough that he would either need to begin systemic chemotherapy or have an enucleation. And as we began to weigh the pros and cons of the procedures, we recognized that the odds of being able to preserve Thomas's eye with really useful vision was fairly low. And there were quite big side effects of the chemo, especially because he was so little, including hearing loss and kidney damage. We also recognized that because we were treating 3 infants at the same time with retinoblastoma, we needed to be very smart about the treatment options we chose and needed to be practical about what we could manage. And we decided that the best choice for Thomas and for our family was for him to have that enucleation. Then 2 months later, Mason faced the same decision. That's the second picture in these slides, where he would either need to begin systemic chemo or have an enucleation. And we made that decision again to enucleate. It was in some ways you'd think it would have been easier since we'd done it once, but it was still a really hard decision to make. So I guess third time was the charm, right? Luke, during treatments, had some complications, which resulted in him losing almost all vision in his left eye. And so basically it was a dead eye that, while it currently didn't have any cancer growing in it, it had potential to continue to grow cancer and would need a lot more monitoring. And so again, we chose to reduce the effects, the amount of treatment he would need by enucleating his eye. And that procedure happened 2 days before he turned 1. So all of those enucleations happened within about a 9-month period. And over that course of the first couple of years of treatment, they had about 70 surgeries combined. And I believe we traveled to Toronto about 20 times. So it was busy. And I thought I'd just share a couple pictures that maybe would help you catch a glimpse of what treatment was like. We were often racing from 3 different appointments, you know, one at the ocularist, one starting surgery, one being admitted, and trying to manage all that. Thank goodness I had a really strong support group of family and even friends who would travel with me to their treatments. And just, I wanted to highlight how much they still thrived through these treatments. So on the bottom middle picture is them dressed in their Halloween costumes as minions. And if you look at their hats, 2 of them have 1 eye and 1 has 2 eyes, because Luke at that time still had 2 eyes. So we tried to find ways to embrace what was going on and, you know, kind of make light of things. And then on the bottom right picture is on them on their 2nd birthday. And I just love how this picture shows their strong personalities and how happy and how much they're thriving. And that we finally had trained them to wear glasses, which was no small feat. I don't know how many times I had to walk back after they'd thrown them out of the stroller on our walks, or tried to eat their glasses, or they did that with their prosthetic eyes too a little bit. So it was quite a fun challenge. But now the triplets are 5 years cancer free, and we feel like we are starting to be on the other end of the program, you know, focusing on survivorship and wanting to play a greater role in helping other families who are going through the early diagnosis, the beginning stages of retinoblastoma. I've had the opportunity to participate in One RB World. I attended in Dublin in 2016, and I attended virtually the DC conference in 2017. And I just have loved the platform that One RB World gives us to meet with health professionals and patients all over the world, and really give us that greater understanding of the challenges that retinoblastoma faces worldwide, and help us want to collaborate more to make retinoblastoma treatment better everywhere. I also joined the Canadian Retinoblastoma Research Advisory Board and have been an active participant in that. I've been able to attend yearly symposiums where we get to meet in person other patients and families, and also clinicians and researchers. And that's something I really enjoyed, is continuing on those relationships with our doctors that we're not seeing quite as much, but also meeting those people in their circle of care that I didn't necessarily know existed during treatment, such as the researchers who play such a big role in the future of retinoblastoma. It's also given me the chance to meet other clinicians around Canada, including Dr. Paton, who I've had the chance to co-lead this session with, and it's really been good for me to have that opportunity. I've participated in working groups where we meet monthly trying to push forward research projects. And I really enjoy that chance it gives me to continue to stay connected throughout the year. I also, because of my participation, was invited to attend the ARVO conference in Vancouver, and that's a big research vision conference that I didn't know existed, but I guess it's kind of big time. And a few of us who spoke in our small breakout session had an opportunity to be published in the Journal of Ophthalmology. So that was another really neat, rewarding experience for me. One of the newer initiatives that the Canadian Retinoblastoma Research Advisory Board has begun is trying to encourage patients or parents to work with clinicians or researchers to explain what the research is really saying. Because I know when I try to go read a research article, I don't understand half of it. And so for part of this session, we actually analyzed 3 different systematic reviews of IAC treatment. And I won't go over all of this because it's going to be shared as part of the content for One RB World. But I wanted to highlight what we were able to explain in plain language about what these systematic reviews have been showing. And systematic reviews are articles that take several different research studies, combine them together to create larger content of data for understanding what's going on with the research. So just to highlight a couple of things, most of the studies have found that there's a 60 to 70% rate of being able to save the eye using IAC and other treatments. But there are some flaws with it, including the short-term follow-up that almost all these research studies have, and not being able to show those final outcomes because of that short-term follow-up. And just to include on that, they're only talking about eyes saved and not necessarily on all of them, not what vision was saved. And then another really other concern with these papers that highlights the need for this to continue to be done in research is that only 38% of the papers mention anything about metastases, and they are showing a 3 to 4% rate. But again, that's something that these articles are highlighting that needs to continue to have more research studied on them so that we can understand the risks that if there is a greater risk of metastases. But just in conclusion, IAC is a good treatment that can be offered selectively among other options with fully informed discussion about all possible risks, benefits, and uncertainties. And as we highlight so many times in One RB World, eye salvage is only valuable when achieved without risk to life. So I hope you can see through this article summary that it's so important for parents and patients to play a role in retinoblastoma. And whether it's these article summaries or participating in advocating for treatment to be covered in your country, or fundraising for various charities that are involved with retinoblastoma, there's so many roles that parents and patients can play. And I'm so thankful I've had an opportunity to play a role. And just to end, I have a picture of my family after we hiked up a mountain with a beautiful view of Waterton Lakes National Park. And I just wanted to share that going on this journey of having triplets with retinoblastoma is never something that I don't think any of us who've had to fight this battle would have chosen. But as we're able to get to the other side and see the views and see the wonderful people we've met and see our children thriving and see the future, the potential of the future of RB, it's just so inspiring. And I'm so thankful for the better person it's made me become because of my experiences. And with that, I'll pass it on to Dr. Paton.
I would like to talk about new treatment guidelines and new treatments. I would also like to acknowledge folks who are working on patient engagement and the patient engagement keynote. As you will see as part of our discussion today, that's really key to what's going on with all of the components of good, safe treatment. So we are together because we are all on planet RB for one reason or another. I think there are 265 registrants from 38 countries here, all traveling the same road with some variations, and now with friends around the world to be able to do that. We probably all have one vision, and that big dream is that there would be a world without retinoblastoma. That's the big dream. But the first step maybe would be a world with no retinoblastoma deaths. And if we can dream a little bigger than that, with no deaths and healthy functioning kids, with a good usable vision in at least one eye. And then the other real dream is save both eyes safely with vision. So how do we get to this big dream? So I wanted to talk about that place where we go next after the nice talk that Dr. Eppelman gave yesterday, where we've done the screening. How do we get to the next piece? Our organizers kindly provided us with a list of questions that had come from participants. And our goal today isn't necessarily to the very specific questions, but to give a framework for answering them. So after our big dream of a world with no retinoblastoma, we'd like to set goals and then take action. And one of those kinds of actions that we can take is guidelines. So what are guidelines? Guidelines have a very specific language around them. And although guidelines sound like something we put on a road or use in a kitchen, they are a little bit like this. We use the word cool to mean really cold, but you may also use the word cool to mean like the group on the other side there. And so the terminology around guidelines is very specific and has become very much more complicated and enshrined over the last 30 years. It started because people wanted to understand what the best thing was to do. And now there are international organizations in multiple countries, including clearinghouses and the authority of the clearinghouses has also changed. One group that was very active in the US is no longer there, but there's something called the GIN, which is an international clearinghouse and has a library of about 3,000 guidelines and about 38 members, where they try to incorporate, 38 countries and 108 members, organization members, where they try and regularize the process. There are two broad components to this, and the terminology started with evidence-based medicine. So people tried to construct guidelines that were based on evidence that was verifiable. But there's a second component to it, which I think is what some people think of, which is the evidence-based individual decision-making. You'd like to take the evidence and apply it to the individual who's in front of you. And generally, this is the professionals looking after the patient, with the patient, trying to figure out what to do best in their circumstance. So designing guidelines before this formalized process was often a consensus building exercise. People would talk about what they felt about things. They would compare their notes, and they would express an opinion that then went into the general way that things were done. But that wasn't necessarily always something that had good evidence behind it. It might be preference, it might be the opinion that worked well in one center, but it was very difficult to verify, and many things were done in this fashion. After the formal process that started in the early 1990s, we found a much more rigorous process and requirements for something to be called a guideline. And the complicated diagram on the right isn't meant to scare you off, but only to show that it's got components. You need to start with why are you doing the guidelines and who has some contribution to make, and also needs to be at the table when you're putting them together. If you don't engage the folks, including the patients and parents who are going to be affected by them, you won't get a guideline that's meaningful. And this specifically suggests that it should also be local. Not too small, not too local, but appropriate to the patient population and the setting, including the resources that you're talking about. To develop those guidelines, you need to ask a question, and the questions have to be asked in a particular way to be able to search for evidence. You search the literature, you grade the evidence. This is one piece of this exercise that has gone through multiple iterations and has at least 3 or 4 different ways of grading how good the evidence is. What you heard from Leslie was a little bit of conversation about evidence around intraarterial and the difficulties comparing papers and understanding what the evidence really is. And then the group, after having graded the evidence and looked at the material in it, is supposed to make recommendations. They get disseminated, implemented, and then they're meant to be periodically updated. The good news for this international audience is there's also a methodology worked out called ADAPT, with an E on the end of it, that is supposed to help use these guidelines and translate them to other circumstances. But what are the guidelines not? They are not a recipe book for treating a particular eye. That still falls to the individual local area. And as you can see from the 3 twins, in spite of the classifications being different, the outcomes weren't always all that different. It needs to be done based on the individual, based on the eye. So we made Canadian retinoblastoma guidelines, and I want to acknowledge both Helen Damaris and her group for the wonderful work they are doing, that they were doing in the background at the time this guideline was being developed 12 years ago. And particularly to acknowledge Brenda Gallie for her visionary way of including patients and parents at the time. The process was slightly chaotic, almost always a bit of fun and cause for hilarity, and actually came out with guidelines. Generally, guidelines are meant to be for something that's high volume and frequent. And in fact, this was done for a low frequency disease. So we were breaking rules trying to do this. However, we wanted to ensure equivalent access, and that can't be totally equal, to high quality care for a relatively small population in a relatively large country. Our target audience wasn't only practitioners, it was actually some of the funders, the policymakers, the care provision organizations, for them to understand what good retinoblastoma care looked like in order to be able to ensure that people would get that. So I've just outlined the committee structure here and the different chapters and the guidelines to give you an idea of what was put into it. We tried to cover all the pieces of it. One of the important pieces here was talking about the classification and features of a retinoblastoma treating center, but you will see that there is everything from the screening to referral and diagnosis, follow-up, psychosocial care, public awareness and education, and references and recommendations, as well as for treatments, which might be the piece that you think of as needing guidelines. The only other really formal guidelines that have been published, and the Canadian ones were published, which was a big feature of it, published and adopted by the Canadian Ophthalmologic Society, are the ones that were created in Kenya. And Kenya articulated why they were doing them. They wanted to create awareness, improve the quality of treatment and the access to standard treatments, support the families, and mobilize resources. There are small pieces of retinoblastoma care that have guidelines around them, including an American Association of Ophthalmology and Ocular Pathology guideline on screening. The We See Hope website has a guideline reference on it, although it's not really a guideline. But if you do a current search, this is the only other guideline. What are the keys to guideline success if you needed or wanted to consider making a guideline in your area? This is courtesy of Cynthia Lank, who was our editor and assister for the first ones. Clarity. What are you doing with them? What are the timelines? Who have the roles and responsibilities? Making sure it's managed, using a proper medical librarian so that your resources are well used, and also that your results are provable and approved by organizations that look at guidelines. The business about hiring an editor was to make sure that it didn't sound like it was something written by a committee, but that it hung together well, and that the people working on it should meet face-to-face at least once. I also think it's important for it to intersect with other guidelines. We haven't really got there yet, except to say pediatric radiology and adult radiology need something in them about retinoblastoma and exposure to x-rays. The same would go for dental radiology. We're not really there yet. Somebody has asked about screening and children. And in Canada, there's something called the Rourke Well Baby Record. It was somebody's way of handling a practice and not forgetting anything when they were first in practice and covering the whole waterfront of general practice. They wanted to make sure they didn't miss things they needed to do. And the Rourke Baby Record is now used internationally and has multiple things, including commentary about screening children periodically for red or white reflex. And then with that, I'd like to stop and pass over to our next panelist, Vera Esuman from Ghana, who's going to talk to us about her program in Ghana. Thank you.
Okay. Hello, everyone. Good evening. I'm happy to come your way this evening to share our journey towards establishing a national strategy for retinoblastoma in Ghana. I'll be looking at the need for it, the goals, achievements so far, and the next steps. So Ghana is a small country in the western part of Africa, West Africa, with a population of 30 million by World Bank statistics, that is as at 2019. 40% of the population is aged less than 16 years. It is a low middle income country. Ghana shares in the burden of retinoblastoma. Ghana shares in the burden of retinoblastoma, where it is the commonest ocular tumor in all ages, especially in my hospital, where the patients present with late disease, both clinically and histopathologically. About 65 cases are seen yearly in peripheral eye clinics across the country. And it is the third childhood cancer in my country. The plight of children with retinoblastoma in Ghana is illustrated by the stories of two children who actually motivated some of us to start this journey of trying to establish a strategy. Elo, a male, was diagnosed with bilateral retinoblastoma in 2010. He had enucleation at the age of 7 months in one eye. The second eye had multiple tumors of grade A and stage A and B. So we did not have the means of offering focal and local treatment in country. So we sent Elo to India. We thought the visit was going to last for just 6 months. But it turned out that Elo spent 4 years in India because of recurrences and because they could not afford to come back to Ghana periodically. He did not have the opportunity to go to school, and he did not have friends to play with. He got back to Ghana at the age of 5.5 years. The problem there was lack of funds and unavailability of full complement of treatment in the country. Whilst in India, MY, a female, also came in and was diagnosed with bilateral retinoblastoma at the age of 5 months. She had enucleation in one eye a month later, but the family could not afford treatment abroad for her solitary tumor, which was group B in the second eye. We extended the systemic chemotherapy for up to 12 cycles, hoping that it will control the tumor. Unfortunately, she lost her vision by the age of 1 year. And so we had to enucleate the second eye because the tumor was growing fast and had almost filled the eye. MY got enrolled in the school for the blind at the age of 5 years. But 6 months later, after enrollment in school, she presented to our hospital with seizures. During the period at home, they could not afford periodic neuroimaging. But on admission, neuroimaging done, MRI showed that she had this huge pineal gland tumor. It turned out that MY had a trilateral retinoblastoma that was not picked up and which took over the whole brain. She died shortly after that in August 2017. The death of MY actually sparked something in some of us. And that was the beginning. We had already started talking about starting a strategy, but this was the last straw that pushed some of us to take action. So I then heard of the One Retinoblastoma conference, which was coming off in October that year. So I approached one of our partners to sponsor me to the conference. And my aim was that I was going to meet world leaders who could help us to start a strategy in my country. So I came for that conference. But at this stage, anecdotally, our overall survival of retinoblastoma was less than 50%, which is so currently. And there was no Center for Comprehensive Management of the disease, no national guidelines, and funding for management was a challenge because even though we have a national health insurance scheme, it catered for only surgery and supportive laboratory investigation, but not for the other treatments. So in 2017, at the meeting, I saw survivors. Some were old, and that encouraged me that if we put in some efforts, our children could also survive. So that reinforced my conviction that I should start to spearhead this program. Lorna, who is the pediatric oncologist I work closely with back home, was also at this meeting. So we started networking and we met some of the people who actually are helping us now. Brenda is one of them, Helen is one, and Aaron, Dr. Aaron, and some others. So the journey started from 2017. I proceeded to take my sabbatical leave to start this project. And I had to, at a point, apart from going to Wales and other centers, I ended up going to Toronto to understudy the program, the Canadian program, and then also look at how they manage retinoblastoma. These were the goals we set for ourselves, that we want to improve on the medical care of children, mobilize resources for treatment, because that was a major problem. Conduct collaborative research and underpin it with monitoring and evaluation. We were hoping that we'll be able to improve survival to 80% in 5 years when the strategy is established. We're still working on the strategy, but there have been some achievements which I want to share with you. Presently, there is a retinoblastoma care team that has been established, an interim national committee that is trying to spearhead this national program. There's a draft national strategy which is developed. And I'm saying draft because we wanted something that we could start from and then bring it to a national stakeholder meeting where they will look at it, revise it, and then adopt it for us to start the work. We've had new treatment established. We now have an intrateria chemotherapy. There's laser focal treatment, laser cryotherapy is available. We can now give intravitral injections. Brachytherapy, we now have a certificate to order radioactive plaques. We should have had training this June, but because of COVID, we are planning to have that in January next year with the help of Dr. Aaron Singh. We've had a lot of stakeholder engagement, both at the local level and international front, with the government level, Ministry of Health, the management teams of the major teaching hospitals in the country. We've also engaged the eye care professional societies at their meetings to give them an idea what we are planning and then which we are going to actually work together with them to come up with a strategy for the country. I just want to touch briefly on the intrateria chemotherapy. We had an interventional radiologist who we sought for funding to just have some training in IAC in India, which was done in 2018. We finally started IAC treatment in Ghana in April this year. We've had 3 sessions for the first child. My hospital has a cath lab, but they don't have the software for head and neck procedures. So we had to partner with a private hospital to be able to do this. And we are working on scaling it up for other children. Of course, cost is the problem. We now keep it for children with bilateral conditions who second eye has vision in them and the tumors are beyond focal treatment. We want to offer them that. Now, the other major achievement is the fact that now retinoblastoma, this strategy, even though we have not implemented it, has been captured in the 5-year National Eye Care Policy for the country for the next 5. This was done in June 2019. It's also been captured in the Universal Health Coverage Policy for Ghana under the Childhood Cancer Program, which is a major achievement for this program. Newborn screening and childhood screening has now been highlighted in Ghana Health Service Reproductive Maternal Children and Family Division implementation documents. And we are working with them to ensure that this is achieved. These are some of our external partners who have helped us along this journey. We have a long journey ahead because the strategy we haven't achieved yet. Special mention to Toronto, Brenda, Helen, World Child Cancer, and then Cole Eye Institute. We've also started establishment of an endowment fund to help support these children, and the registration for it as a legal entity is underway. We are hoping to achieve that by the end of the year. We are presently benefiting from pediatric oncology funds, but the advocacy for inclusion is going on, and I give a lot of credit to our pediatric oncology team led by Lorna. They are doing a great work. We are engaging our patients and their families in their preparation of patient stories and advocacy through media. This is the family, the child who received the IAC, and they were on the national television and radio platforms to tell their story and then also to solicit for funds. Already childhood cancer programs led by the pediatric oncology, which includes retinoblastoma parents and survivors, we've been having this patient family engagement. And this is one of the street marches advocating for childhood cancer to be incorporated in the National Health Insurance Scheme. And you can see a parent, that's the first one there, and then a childhood cancer, a cancer survivor, the second red arrow pointing at that. Presently, we are undertaking a national survey to determine the epidemiology of retinoblastoma, the actual stage of presentation, the referral pathways and outcome of patients, because we're expecting that this will form the basis upon which we'll compare or measure success going forward when the strategy is established. But we also have a prospective aspect of it, which we are trying to pilot the possibility of establishing a national retinoblastoma registry. And this is ongoing, and we are hoping to complete that by the end of the year. Of course, this we're now part of Pediatric Tumor Board in Kolebu. We started the last quarter of 2019. And there is, as I said, a multidisciplinary retinoblastoma care team in Kolebu. We hope to establish one in the second. But what's the next step for our national program? We want to make sure that the foundation to support some of the new treatment that are coming on board will be established. We also want to continue with our capacity building, training of professionals, because we cannot talk about early detection when we cannot handle the early forms of the treatments. So we want to continue with the training. Of course, intervention for early detection has started already with the help of World Child Cancer Group, and we want to continue with that. And we want to start full implementation of the national strategy. And I want to thank you for the opportunity for us to share our experiences, because it is a great opportunity to us, because together we are helping these children who are there, who are indeed our future, for them to have healthy eyes. And I want to thank you for your attention.
Now I'm going to talk about some new developments and build on all these most amazing talks for this whole wonderful, wonderful 1RB World meeting. I miss seeing real people and chatting and talking and eating together, but I must say there's been great value in seeing everything like this from home. So the stage of retinoblastoma diagnosis, I will describe briefly. Roles for treatments, process for development and implementation of new treatments. We'll comment on building on what Leslie has already talked about in systematic reviews, and the very important role of team care, which is shown throughout the whole meeting. I'll just re-emphasize. So clinical staging. We have been talking pretty much about Group D retinoblastoma in many talks, and the ABCDE classification has been the standard worldwide. However, it has some problems. So now we are involved to the new staging, which Dr. Ashwin Nalapatna may comment on as the leader of this major new classification. So here I'm showing the C for clinical, T for tumor, and 1. T0 would mean there'd be no tumor in the eye. So CT1, A and B, look as in this diagram, which also I've borrowed from Ashwin Nalapatna, showing a large tumor with a little retinoblastoma, little bit of a detachment there. And these are a small tumor more anteriorly. That would be an A if that was the only tumor. This would be a B, one closer to the optic nerve or fovea, and a larger tumor with a little bit of detachment is a C. and that would be all fitting into CT1. CT2, which is the major kind of tumor equal sort of to Ds, that we can try to save the eye when the nerve is not directly involved by all the imaging tests. And it shows tumor seeds in the vitreous and under the retina, and that would make it a CT2B. E's are the eyes that have, E stood in Lynn Murphy's original description for enucleation, and that still is the case for the CT3 with many different stages of tumor described there. So those are basically the clinical stagings involving to the new classification, which will be able to compare separate studies more directly than we can today. So I'll just run quickly through the different chemotherapies, the different therapies to try to salvage an eye. Intravenous chemotherapy may kill the tumor, has systemic toxicity acutely and chronically, and salvages about 50% of the eyes as far as we can tell. And the chemotherapy, these little orange droplets here, are using in this illustration to be chemotherapy delivered to the patient. So you can see there's a rain of chemotherapy. Yes, some of it will get into the eye and into the tumor, and that's how it has its intended effect. But much of it goes to all the rest of the body, and that's why it has systemic toxicity. The exposure of the tumor cells to chemotherapy is in the order of minutes, and then it's gone to elsewhere in the body where it has all the complications of chemotherapy, damaging bone marrow cells, hair cells, and other serious things, and is repeated every 3 weeks approximately, 4 to 6 times. And sometimes we hear of children who've had much, much more chemotherapy given this way. Intraarterial chemotherapy is an exciting new idea that the chemotherapy rescued actually from old studies. Chemotherapy could be given through the ophthalmic nerve blood vessels, so it goes directly to the eye and doesn't have that splash of tumor for the rest of the body. And indeed, in that situation, the exposure of the tumor cells is also minutes, only when the drug is traveling through the eye, given repeatedly. The tumor outside the eye that might be in the nerve or might be outside the eye or having already traveled potentially to the bone marrow is not diagnosed and not recognized and doesn't receive a real dose of this drug from intraarterial chemotherapy. And then, as Leslie referred to very well, there's an unknown rate of metastasis for following intraarterial chemotherapy, because the papers are very confusing, not comparable, and the focus has been on saving eyes, not on metastasis. So that's a problem of the absence of a proper scientific method to deliver this therapy, to evaluate this before it achieved widespread deployment in children all over the world. And its first publication, in fact, was in the New York Times. So that's not the way science should go forward. And the reason leukemia in children is such a huge success is because it was approached and made better and better by staged clinical trials, one after the other. Now I'll jump to intravitreal chemotherapy. You've heard in that beautiful description from Jessie Berry, and the drug given in intravitreal chemotherapy goes into the direct vitreous, where this arrow represents a needle into the eye in an area where there's not active tumor. And it diffuses throughout the vitreous and into the retina and is effective at treating, I would say, small volume tumor in the eye. And it's an adjunct. It's used with other treatments. So it's added to the other treatments. The drug in this situation probably stays in the vitreous for a few hours, maybe a day, because there's not a very good blood supply taking it away from the eye, and there's no systemic effects. The new treatment it follows an idea generated by Lynn Murphy, who was head of pediatric oncology at Children's Hospital LA for many years. And he dreamt of a way to give chemotherapy to only the eye from outside the eye. And this has now become reality through the work of many people to develop what we call now the chemoplaque, but it has many other names. In this case, it's used in what so far it's being introduced into clinical care as rescue after other treatments. In Toronto, we had one patient who I will show you some details in a minute, who badly needed something new, something different to save his last eye, which was failing with 30 tumors around the eye. So we took his case to the Canadian Health governing body, Health Canada, and we applied through special access to be able to treat him with this chemoplaque. That took a week of solid work to manipulate the system and get people to come on board that this was not a dangerous thing. And we were able to do it. We've now treated 3 patients on the special access program and now have a phase 1 clinical trial running that is accruing patients. Our special access patients showed that there was no systemic toxicity and it was effective against small volume seeds in these eyes. In this case, the drug comes through this little chamber, which is glued to the eye. I'll show you a picture in a minute of it. It diffuses over 42 days, very different time exposure to all the other areas of giving chemotherapy into the eye. We don't think much gets out, but a little bit will get outside, but it's not something that's measurable by any systemic toxicity. And it will treat the whole eye and the tumors in it. This is what it looks like. It's a tiny little silicone device with the drug sitting here. When you turn that over, we're holding it the other way up, you're looking directly at the yellow topotecan that is in the device that's been used. There's 2 versions. One contains 0.6 milligrams, 1.9 milligrams. And when we turn it back after this and put it in its location here, right under this little tab, which is this tab, in this little T-shaped groove, we've put crazy glue, essentially. Of course, we have to use expensive blue-colored surgical crazy glue, but it's basically crazy glue. And we hold it there for 3 minutes. It sticks to the dry sclera, and we close up the tissues with a few little sutures. And sorry to show you this surgical picture, but it does make it clear how it fits in. And the child wakes up and has no patch, plays in the playroom, goes home, and has no feeling or concept that it's in the eye. We recently put it in a 12-year-old who could very much report to us if she knew anything was sitting on the outside of her eye, and she had no sensation that it was there. She was a little bothered by stitches, but not by the device itself. So we've started now a prospective clinical study. It's a phase 1 study, which means its main purpose is to determine safety in patients with participants. We don't call them patients on the clinical trial. You will see in other contexts, we'll call them a patient, but here in the clinical trial, they're participants because they're volunteers to put themselves at some risk that is unknown to determine safety. And we will secondarily describe the toxicities, eye and systemic of anything, and describe anti-tumor efficacy. And the target are participants who have active retinoblastoma remaining after primary standard care. There is another protocol, which is, I think now REB approved in LA, Texas, and almost in St. Jude's. But that study is to treat patients with group D or CT2A and B, but those have not accrued any patients yet. Our study is actually easier to accrue patients because there's only benefit for the patient to try this, whereas the other study delays the treatment a little bit. However, we're going to try and combine those studies to move it all forward and quickly get the phase 1 data. We need to be able to move this out quickly to broader clinical practice. We also will measure the efficacy, the anti-tumor efficacy, not just in short term, but by counting all the treatments and invasiveness of those treatments, like intraarterial chemotherapy is invasive, systemic chemotherapy is invasive of the whole child. that will enable a complete remission of the disease. And that will be a way to score outcomes on a long-term basis. So how are we going to do all this? We are going to use Depict Health. This is a database that summarizes the patient summary of their whole history in retinoblastoma. And many of the other talks throughout this meeting have actually required that kind of long-term follow-up data and the need for patients to know what's happened to them in their childhood as they grow up. So this is a permanent record of the details for one person. And down here are all the things that are shown on the table. I won't take more time to outline that in detail, but these are chemotherapy. This is intraarterial chemotherapy. So now I'll show the one patient who was our special access patient 1, the one that first brought this to Canada and was the first person in the world to receive the chemo plaque. He presented in 2017 with one eye full. This is a drawing which occurs every time the patient is seen of the disease, and all the yellow is active tumor, blue is retinal detachment. Here's a picture, but you can see the picture only shows a little bit of this and doesn't tell the story like the drawing does. So this is his other eye. This would be the left eye, and it was even worse, but we tried to save it, but you'll see we gave chemotherapy and then we removed the eye because we weren't succeeding and the nerve was threatened. And then we gave intraarterial chemotherapy. This is the right eye, which got all the treatments there. And then we were failing. Next steps for his only eye was going to be removal of his only eye or external beam radiation. And that, as you know, is a very, very difficult choice. So instead we put in the first chemo plaque and this is what it looked like when we put it in, 30 approximately tiny tumors and one calcified tumor that had tumor coming out of it, although it had been quieter earlier. Calcified tumor seems to be a very dangerous thing. And a new retinal detachment, which had disturbed his vision, which really brought this to attention. And then we put the chemo plaque in and it had a very, very excellent response. All the little yellow spots that are here are all gone and have never recurred. His calcified tumor also had regression, but then recurred. And he's gone through many different treatments, including 2 more intraarterial, cataract extraction, and then a very unusual treatment, which is also going to be is very useful in this context and will have more role in the future, and that's to take out the calcium. So we just took out this calcium by a vitrectomy, and he now has a very excellent result. He's a long way away from his chemo plaque now and still has no toxicity due to it. So this is a summary of the treatments, shows all the complexity, how retinoblastoma needs all these different treatments for different circumstances for different children. And we're optimistic that things are moving forward in a very good way to make care better and more able to be deployed and treated close to home, because everyone who views this whole course of treatment on a child includes the family and the doctors where the patient lives. So we could all help each other and keep the children close to home and optimize care. That's what we can all look forward to. Thank you very much for the opportunity to listen to all of you through this whole meeting and to communicate my excitement about the chemo plaque and other things and science. Thank you.
So, hello everyone. I built like what Dr. Isuman has shown in Ghana. I've done that around 10 years ago, starting in 2005, from 2005 till 2014 in Egypt. And we have been putting the guidelines as a part of our management. But we found that the socioeconomic and the psychological part of the treatment decisions would impact families, and that led us to try to rethink how we will implement the guidelines. So we treated the DIs with a trial salvage, where we try to save the eye, while the EIs, we remove them upfront. We don't offer them salvage. And then we continue the treatment until the child is cured. And then we retrospectively reviewed how the treatment decision for this advanced eye had impacted their life socioeconomically, regarding the financial burden, the financial impact, where the economics played a role, the psychological impacts, and whether the stress of treating retinoblastoma for the parents had impacted what they decided. The social impact and family unity is very important in Egypt, as usually the males or the fathers are the supporters of the family. So if anything happened to the family, usually the mom is on her own, and this complicates therapy. What's the medical impact of treatment decisions, and what are the cancer risk and spread of the cancer? And we established what we call a socioeconomic score, and we gave each parameter of these 6 parameters a score from 0 to 3, and the higher the score, the higher the negative impact. And we considered the score high if it is more than 50%. So it's either for each unit of more than 1.5 out of 3, or for the whole score out of 9 points out of 18. And if you can go to the next slide, this would help us think what would we treat a unilateral DI, because what we found that the socioeconomic score was extremely high for the DIs that we tried saving rather than the one that we primarily enucleated. This was very significant, if we can see in this slide, that the ocular salvage was very low for DIs, so only 11% out of the group had been salvaged. 90% were enucleated at the end. So is it better to enucleate upfront and avoid all these socioeconomic conundrums or impacts, or to put the families through them and like suffer from all these impacts? And when we look back and we did this research, we have changed our guideline now. If a unilateral with a group D presented to us, we will offer primary enucleation up front, because all of these impacts, unfortunately in Egypt, we don't have any health insurance for treatments. They are costly, the families cannot afford, and we can't start a treatment journey without knowing that we can finish it. The compliance is important, and when the factors governing compliance is out of the hands, so this should be put into consideration. Thank you.
Would one of the panelists maybe read the results for the audience members?
So we have an interesting outcome on this, that people are really, by in a way, influenced by the medical expertise that they're provided with in trying to make their decisions, but that financial, travel and accommodation, significant impact on people, as do work-related challenges and stigmatization. So it's not a simple one thing, it meets all. And we have the opportunity to make a difference in people's lives if we think about what's going on. Once people had their knowledge, almost everybody said knowledge helps. I think this is a really marvelous endorsement of patient engagement and patient education. Clearly, people want the information, and we hope we're helping you to get that as part of this, and maybe you will help us understand how to do that better. The biggest challenges, if people gave top 3, were stress, financial, and travel and accommodation. So the simple things were the ones that were the most difficult for people to look after and have a profound impact on the families. So I would like to ask, as a mom, Leslie, could you say something about that, even here where you can get care delivered through the Canadian healthcare system, and you have access to a wonderful expert and a team behind her?
Yeah, so you want me to highlight just where I find my knowledge, right? Okay, so I guess just highlighting that it helps so much to have a team that you trust to get your information from. But I think sometimes when you're going through it, you're wanting to relate to someone. And so sometimes social media becomes an important component of that. But being mindful that the knowledge you're receiving through social media may not always understand your specific case and your child's diagnosis and the knowledge that you need to understand because of that. And so that's why it's so important to recognize that those who are treating your child be able to trust your physicians and be able to gain knowledge from them. And then I really was surprised how many said they looked up scientific articles, actually, because those were so overwhelming to me when I was going through treatment. I didn't have time to really research those. So I think that's fantastic to see that many parents and are researching, really doing their research.
The first question is for Brenda. The attendee wanted to know how widespread DPIC Health is used in Canada and if patients have access to their own information via DPIC Health.
Thank you very much. That's a great question. And I wish the answer was it's widely used. We actually are using it unofficially because it still has not gone through all the legal, final, technical things. Part of the, because we've set it up using the Azure cloud so that it will be available to be used worldwide, that's caused a whole lot of further things that we have to technically master. And the legal aspects of its secure privacy protection and all of that is being well worked out. And so it's only used as a demo in Canada where it shows very powerfully how we can share care across the country because we all can look at it. DPIC Health should be the parents and anyone else they choose to authorize to view it can view from outside. For example, their GPs, their pediatrician, the grandmothers, anyone they choose, and they authorize those people to be able to look at their child. And then the clinicians caring for the child enter the data and use it. So it's built on a previous version that's been used in SickKids since 2003. This is much more sophisticated and has all the power to go global. It's not quite ready to launch, but Caitlin knows very well. She'll probably tell me I shouldn't say this, but I hope it's running across Canada by the end of this year. And very quickly, it will next run in Africa and Ghana. Ghana and Ethiopia will be leading centers to use it. We already applied for a big grant for that with FIRA, which we still don't know the answer on, but we'll do it anyway. Thank you.
Thank you so much for that. A couple more questions for you, Brenda, pertaining to the chemo plaque. The first question is from Paul Finger, who wanted to know if the position on the eye affects the chemo plaque.
It's a good question. We don't think it does. There is a scar that develops directly opposite where the chemo plaque is. There's retinal edema and choroidal edema and a scar. We started to always put them inferiorly because, as was pointed out earlier, that the visual effect of superior scotomas is much less than inferior because you need your vision looking down. So that's why we put them inferiorly. It's also technically easy. It seems that the drug diffuses through the whole eye. So in terms of where it is in relationship to the tumor is irrelevant. Patient 1 had 30 tumors all over the eye and they all disappeared. More important is that the dose we used is not the we can go in our study up to 1.8 milligrams. We've only used 0.6 in any patient yet, and we think things like calcified tumor and bigger tumors are going to need higher doses.
Just a couple more follow-up questions from audience members. As you can imagine, there's a great deal of interest in the chemo plaque, and there's a few people asking how they might volunteer to receive the chemo plaque. And also an audience member wanted to know if you anticipate the chemo plaque replacing IAC in the future.
First of all, you can contact us, and it depends totally on the stage of tumor in the patient's eye. We have treated, so every patient on our study has to be a SickKids hospital patient, but when they aren't, their primary care doesn't need to have been in SickKids. They can come from elsewhere and come to SickKids when they are eligible for the criteria of the study, but then they would have to stay near SickKids for 9 weeks of the study. What was the second part of that?
The second part, sorry, I should have asked them independently, was whether you thought the chemo plaque might replace IAC.
Oh, yes. I think it will, it has the potential to do so, but they are different. And at the moment, would not replace all IAC. IAC has a good role in part of the care for a child at the moment. Someday it might, when the dose and everything is complete. The other thing is this chemo plaque that is under study, it only contains topotecan, but there are other chemo plaques under development that will follow along the line of what Jesse Berry talked about with targeting specific molecules, and those will be much more powerful, we would anticipate, and may make the chemo plaque a major primary treatment for all retinoblastoma. That's the potential. That's looking forward. Maybe the next one, RB World.
That sounds great. Sammy, I noticed you acknowledged that you might want to answer one of the questions live. Is that right?
Yes.
Please go ahead.
Yeah, so from Dr. Aminu, Dr. Abdul Rahman, he said that he had 4 goals in his treatment in Nigeria, and this is a very good concept to adopt. It's only not saving life, globe, and sight. He added a fourth goal, which is saving the family, because the family usually go bankrupt in cases of advanced disease. And I would emphasize that this is a very important concept, and in developing or low-middle income countries, this should be adopted while putting guidelines. This is a very important aspect, and I really like his input about this. Yes, family needs to be saved.
Thank you, Sammy. And then Ashwin, would you mind addressing this last final question?
Sure. The question is that the work about RB tumor staging and definition is so foundational, and comparing studies and outcomes across the RB world. How broadly is the staging system being adopted across the RB researchers and clinicians, and how can RB survivors and families help with its adoption? That's a great question. So far, if you look at the uptake of the staging system, we've had about I think close to more than 40 peer-reviewed references to the staging system. So I think it's slowly being adopted, and slowly people are understanding why it's that important to to have a uniform platform for the staging of this disease. How can RB survivors and families help? I guess the first way the families can help is to start asking which stage their child is in or was in, and that will sort of start to have people think and start to use the system in a more retrospective way. But going forward, I would encourage everybody to know their stage. This staging system is useful in more than just the eye treatment way. It's also useful in terms of how you are at genetic risk or not, whether there is risk to life or not. So it's actually quite a comprehensive staging system. So I would encourage any future family to really know their stage and maybe ask their doctors which stage they're at, to know more about their prognosis and their course forward. I think it'll be a great thing if families can encourage information like that from their doctors.
Thank you very much, Ashwin. I think that concludes all the time we have for this panel, but we thank you to all the panelists. That was exceptional.